All right, so today, something I'm super excited about. Um, we have some community health workers here with us. They all come from very diverse backgrounds, um, and they are joining us from various locations. And so I'm super excited. We're kind of going to do this in a panel format. So I have some questions for them that I've written out, and then I also have want to invite all of you to be thinking of questions as well. Um, as you know, Echo is a very collaborative experience, and so any questions you may have, I want you to feel safe and comfortable asking those. So really quick, I will introduce them, although mostly they're going to introduce themselves. Um, I, um, but we've got four that I'm aware of. I know one is having some trouble connecting, but she should be here shortly. But we have, and I apologize to them all in advance. I am probably going to butcher their names, but they can correct me. I won't be offended if they correct me. After all, it is their name. So I want to make sure that um, that's right and that you all are getting that right. So we have Oretta Tupola, Kathy Wolfsfeld, Jeanette Viata. Are you Hispanic? And then Valentine Mukundente. And I know I'm sure I butchered all of those, but um, super excited to have all four of you here and excited that we'll have a chance to collaborate with you today on health equity, and especially on your role as community health workers and how you can help those who are on this call who are practicing um, in various areas across the state in achieving health equity. So first of all, I just want to give each of you a chance to introduce yourselves. I'll go behind the curtain here. I sent them all these questions in advance, so they had a chance to look over them, but I didn't give them instructions on how to introduce themselves or what to include. So whatever they want to say about themselves here, they're gonna have the chance to tell us all about. So let's just start, Oretta, let's start with you.
Hi, my name is Oretta Tupola. I am originally from Hawaii, but I moved here 6 years ago to Utah. I am working at the University of Utah. I wear several hats. I work at the Utah Public Health Association, leading the build of the CHW workforce here, and work with all of these lovely ladies and several different projects across the state. But I have a background in social work. And got into this work as a young child, I believe, born into this CHW work, just helping family members and community members through the work that my mom did, and watching her and observing her help others get connected to resources. And then eventually, it became my role even in high school, like for my friends and for other family members, as I am the oldest child of in my family. But went into the field of social work with the goal of continuing to do the work I did as a community volunteer, and then it has led me to different places and spaces, and I just feel like this work of CHW's really has contributed in the history of everything to the work of equity, even though a focus of equity this year or this since pandemic has become the forefront of our nation's focus. But yeah, and so I'm glad to be here, and especially to be on this panel with my other CHWs.
Yeah, look, I don't know if everyone's view is the same as mine. Let's just go down the line. Jeanette, do you want to go next?
Thank you, Austin. Yeah, my last name is Villalta. My name is Jeanette Villalta, and I'm original from Guatemala. I've been living in Salt Lake City, Utah for the last 26 years, and 22 years been working with the Hispanic Latino community here in the state of Utah. My background originally is in business, and when I came here, that is just the past because my new my new life path me to the CHW work. I've been working with the community and different aspects of health, mostly in women's health. That's kind of my target with the community. Since 2012, I've been working in recognition of CHWs here in the state of Utah, because of the work that they do in the community. Sometimes it's not appreciated and it is invisible sometimes. And we start that movement, and now we have a huge group of CHWs here in Utah. The leader is Oreta now, and she's doing amazing work with all of us, guiding us to do a proper job and continue working as a CHWs. And I've been working with the University of Utah in research, and I'm part of the AHEC program as well, and working with the students, the medical students. And I'm happy to be here to share experiences with you. Thank you so much.
Yes, thank you, Jeanette. I knew I was missing that L. That's kind of embarrassing because I actually speak Spanish, so that's
Really?
embarrassing for me. Yeah. So that's my bad. Kathy, why don't you go next?
Thank you. Good afternoon, everybody. My name is Kathy Wolfsfeld, and you did a fabulous job with my name, especially getting that, leaving the I out. So I'm a community health worker serving the African American community, and I work out of the Calvary Baptist Church in downtown Salt Lake City. My passion is diabetes prevention and women's heart health. And so I gravitate toward those issues. This is totally out of my realm, being a community health worker. I have my degree in physical education. So I was a PE teacher and a coach and a referee and all that stuff. And one day my pastor at Calvary said, "Hey, I need you to come and work with these women on this study." So I found that I have a passion for working with people, helping people, trying to find resources, trying to find ways to meet the needs of those that don't have. And so that's how I got into being a CHW. It was purely by happenstance, but I'm here to stay. I also work with these fine ladies in the AHEC Scholar Program and the School of Medicine, where we work with the students on cultural humility. And, you know, we try to work with different groups to get them to understand where we are coming from as a different culture than what they're used to seeing, and to try to make it not so scary. Thank you. That's about all I have for me.
Thank you. And then finally, Valentine, and you can, again, you can correct my pronunciation there. I don't know if how I did, but.
Yes, my name is Valentine Mukundene. You can call me Valentine, Valentine, Valentino. It's all okay. I speak 6 languages, so whatever language you choose, that's fine. I'm originally from Rwanda, and I have been in Utah for 22 years. I came to Utah as a refugee, and I'm the executive director for Best of Africa Group. This is a nonprofit organization. We serve African refugees and immigrants of Utah. They can be people who have been here for a long time. They can be new arrivals. We focus on integration to make sure they are well integrated in a new society here in Utah. We also focus on advocacy to make sure we are being a voice for our community, especially the fact that some of us, most of us, English is not our first language. So sometimes we struggle to understand documents or instructions written in English. And we also focus on empowerment to make sure our community members, they get a job, they become successful. I have worked with different organizations like resettlement agencies. These are the agencies that help refugees to come to the United States. I also worked with state organizations. I'm also working on different projects with the health department. I have worked with the University of Utah. My education, I have a master's in public administration, and I'm also spending my time educating providers, including future providers like medical students, especially through the AHEC program. And I really appreciate spending this time with you.
Yes, and I'm gonna preempt the end here where we usually thank everyone, and I will still thank you at the end, but want to thank all of you for being here with us, because we've talked in this series a lot about addressing health equity across the board. We've tried to dive into some specific things, but I can't think of a better group to talk about what health equity looks like on the ground, on the front lines, what that really looks like. And that's a big part of what at least my understanding of community health workers and what you're doing. So I'm already going to throw a curveball. This question was not on the list, but I think it's a good way to start the conversation. What does health equity, what does that mean to each of you? How would you, it's hard to nail down a definition of health equity. So what does that look like to you? How do you see it in your work? And I guess, what do you envision the future of health equity being in the state of Utah?
Well, for me, sorry.
Go ahead, Valentin.
Yeah, for me, health equity is when I look on the provider side, I think the provider has to keep in mind of different people that they are taking care of, what communities they from, what culture do they come from, what languages do they have. It's not only providing different services, but it's also to make sure the services you are providing make sense to the people who are receiving them. For example, for our refugee community, like I said, many of them have less English skills. So you want to make sure you are providing interpreters during your services. You want to make sure you know the best communication method for patients. Some of us, some of us are comfortable scheduling appointments in person or online. So those are kind of details that I would like providers to keep in mind. I know since we are different communities, it would be impossible for providers to understand and each details from each community. However, when you connect with the community leaders, they will help you deliver the message. Since they are trusted people in the community, I feel like the connection between providers and communities is so important.
Well, I would like to say that health equity to me is having equal access to clinics, to hospitals, to doctors, to nurses, to telehealth, all of that. You know, we have different types of deserts around our community. We have food deserts, we have internet deserts. You know, we just don't have access where the people are living. You know, the access is mostly on the east side of the valley, or it's not on a bus line or, so it makes it so difficult for people to get to healthcare. So most of the time they don't. They just wait till they have an emergency and go to the emergency room. And then insurance, or the lack of insurance. Our country is trying to do its best with getting everybody insured, but there's still such a disparity with insurance carriers and the type of insurance. And I believe that from my experience, the type of care you receive coincides with the type of insurance that you have or don't have. Doctors don't turn people away, but if you don't have insurance, you're more likely to be sent home with the Tylenol and, no diagnosis or anything, more than someone that has full coverage. And so, those disparities, where people live, do they have sidewalks that they can even walk on? Is it safe for them to go out and try to get to a bus stop or try to get to the doctor, try to get to, a grocery store? And so all of these disparities lead to health inequity. And so I would like to see just more like equal access.
I would like to add something to what Valentine and Kathy just said about access and access to medicines as well. The system in C is complicated and more for, I'm going to talk about my community in specific. In our countries, we don't have that kind of system where you have to have insurance and go to the doctors. The doctors that the insurance is in the network of the insurance that doesn't exist in our countries. And when we move here, the system is complicated. Navigating the system is complicated. And when people without insurance finally get an appointment in a community clinic or sometimes a private clinic where they have to pay, the time that the people are seeing is so short that they cannot express very well what they want to say to the doctor. And as Kathy was saying, the language, and Valentine mentioned that to the language, sometimes the short time and, when we have that language barrier, it's so hard to explain everything so fast to the doctors, and the time is so short. And at the end, they just give the prescription or the treatment that they have to do, but they don't know the background of this person, if they have insurance or not insurance. And for me, equity would be said that, right? Like access to the services, access to the medicines. I know this is something huge, maybe that is not in your hands, but this is like the dream, right? Like people have access to quality of care and access to treatment, access to medicines. Right now I have a client that she was diagnosed with HPV, and the doctor just says she has to have a vaccine, and the vaccine is $1,000. This is a single mom without insurance. She's a very low income, and we're looking for something that can be more affordable for her. But that's the thing, and the equity of the system. The system is complicated, and all these barriers for people to access to quality treatment, the barriers are there, right? This is so big, but it's the reality.
I think what I'll just add to that is, I think equity, it may be something that's very simple for others to understand, recognizing that not everyone has access to everything, but also acknowledging that everybody starts at a different place, just as these other women have shared, but that we have to make these different adjustments. And I think that's where a lot of people don't really understand why these adjustments, why do we have to do these different things. And a lot of blame is placed on communities who who are struggling to access these or who are facing these barriers of resources. And people feel like, why do we have to make these specific adjustments? But if you understand why their inequities exist, why we are facing, this struggle, I think that will help us to empathize with why these adjustments need to be made. I think for us, our stories are shared in a lot of these panels and in a lot of these conferences, explaining why we as CHWs are doing the work that we do. But this is the adjustment that we've had to make on our own as volunteers, as community workers, not getting paid, not getting recognized for the shared experience, our lived experience, for this expertise that we have in order to help our most underserved communities access these resources. It has been a struggle of survival for many of us because we don't have the knowledge of how to go through different processes, whether it's applying for medical insurance or understanding your medical insurance once you get it. All of these different things that for some should be very easy, right? Oh, there's so many resources. Why do you have a hard time accessing them? Because they're available to you. If we don't have knowledge, if you don't understand, again, the underlying causes of why we don't have access, then it doesn't help to make the adjustments and the changes that we need to see so that everybody has equal access. And I think that's what equity means. And that is the basis of this work we do, of CHW work, is really to help those who don't understand or don't know about these resources, how to access them by addressing the language differences, the cultural differences, socioeconomic status, all of these different barriers that our communities face in order to get that same access that others get. And even then, when we get there, there are so many other factors that play into why we still can't access them when it comes to wages, equal pay, all of these different things. And it's not just one fixer up, like fix it all things. There's so many things and levels of things that need to be addressed within the current system that will get us to a place where there is equity across all, communities. And that is something I think we as CHWs are addressing from the ground up, not just by connecting community members to resources, but by building capacity for our communities so that we are able to access these resources without a CHW. That's our goal, is to not have a job pretty soon. But it's a long time coming. It has been a long time coming. And finally, we have been able to get some kind of recognition for the expertise that we have within our communities, and to get paid what we should be getting paid, and to hear our voice, to share the reasons why we face these barriers. And so I'm grateful for these kinds of platforms that allow us to share this information, because for a long time it wasn't valued, right? If we didn't have a degree or a certificate that said we have this expertise, no one was listening to what we have been saying has been the issue for decades. And now that we have this platform to share and to be equal partners at the table, decision-making tables, we're wanting to address not just community level issues, but all micro, meso, macro levels of these discussions, so that we can be a part of these decisions that have been made for us for a long time that have not been effective. And so it's a huge question. This is a loaded question, Austin, sorry. but this is where we have been working. This is not just where we are starting. We have been doing this for a long time. And right now, I think we are at a place where our voices again have been making a difference, especially in implementing at a policy level what needs to be changed, so that on a community level we're more effective.
Yeah, well, yeah, no need to apologize there. I know that's a loaded question. I think that's part of why I made a joke in our first session. This is a 6-part series. We're on part 4. And I made a joke in the first session that this could be an ongoing session from the beginning of time to the end of time, and we still wouldn't cover everything. I still think that's true in regards to health equity. I just think there's so many aspects to it. And of course, we're doing our best to address it, but and we're not going to find all the answers in a six-part Project Echo series, but it is a hugely important thing, and I think your role as community health workers is a huge part of that. So that does lead perfectly into the next question. And you mentioned, Oretta, that it's a field that's been around, but it hasn't gotten a lot of attention, and now it's finally starting to. And I think we're seeing a lot of growth in the field, a lot of new opportunities there. But what is a community health worker? What is the and what have your experiences been? And if you could touch on and you did a great job already in your introductions and in the previous question, but what is the goal of a community health worker? What does that sort of look like in your day-to-day work?
I think I'll go first since I went the last time, but just to share this, a community health worker, you can go look up the definition by the American Public Health Association. Utah has adopted that definition. It really is a scope of practice. CHWs are defined as people who represent the communities that they served and address things like social determinants of health. But what I'd like to share mostly here is really we are an extension of every profession we could be. We can fit. Everybody asks, well, oh, are you only in clinical? Are you only on community level? But no, we have been an extension of a lot of different professional environments in that, everybody has a scope of practice where they serve, and then there's an end to that service, right? The issues where the equity comes in for our communities, that once the services are given, like, oh, this is what we do, this is where you go, the barriers start to kick in of language, of transportation, of all the, can't afford it. And that's where CHWs pick up. We're there to help them access resources that can either pay for transportation, get a voucher for transportation, get families or transport them to a food bank if they need food. Our profession is very connected to Maslow's hierarchy of need, in that we understand if these needs aren't met, I'm not going to go to the doctor. That's the last thing on my mind if I can't feed my kids. So we're addressing those things so that our community members can access these resources that sometimes are not thought about in a lot of appointments that we go to for care. And so I really maybe we have to add that, Jeanette, to our definition, but we are an extension of many different professions in that we really help connect community members to resources by addressing the social determinants of health and other barriers that they face.
Yeah, Oretta said that, and the other part about creating capacity. I think we do that with the clients. We trying to empower them by showing the system. I see that CHW as a link between services, organizations with the clients, because sometimes they don't know that the service exists, and they don't know how to access to that. And part of our job is that, right? To connect them with those services and empower them in the way that they can advocate for themselves. One of the things that we do use a lot in CHW is do it with them, do it for them, we do it with them, and then cheer up. Like, we help them the first time, and then we teach them how to do it, how to advocate for themselves, and then they can do it by themselves. And then you as a CHW make sure that in the next time they will know how to advocate, how to find those resources, how to take care of their own health. Because for example, in my community, that happens a lot, right? Like, the doctors are authority, and whatever the doctor said that's what it is, right? And sometimes they don't feel comfortable with the doctor, but they cannot say anything because they feel like I can't. And that's one of the things that we do. We say, yes, you have a voice. You can talk to them. If you don't like your doctor, you can change it. We make sure that not just to provide, oh, this is the resource and you can go ahead and find it by yourself. No, my job is to call that services, make sure they have someone that speaks Spanish. If they don't have anything that speaks Spanish, I will do it. I will translate. I will do everything for this person. And that's the way that CHWs work, right? Being the link between the services and the client, and in my case, with my community members in the Hispanic community.
Well, I would like to say that community health workers, we're just normal, everyday people like everyone else. We share ethnicity, language, life experiences with our community. And so being in the community, being around our community, that's what makes us an expert in our community, because we're out there. We're in touch with what's happening, what's going on. So some community health workers offer translation services, like Jeanette said, if it's needed. We offer culturally appropriate health education and information. We help people get the help they need. We advocate for health needs and resources. Like Jeanette said, that we're the link. I say that we bridge the gap. We bridge that gap between doctor and patient, or the resources and the client. We're there to make those connections and help them, like Jeanette said, advocate for themselves. We like to be a listening ear as well for our community, because there's a lot of things that happen that, you know, I don't know, either in the news or something, and so people talk. And so being that listening ear builds trust. And if we don't have trust in the community, then you don't get anywhere. And so we build that trust with our community so that they can tell us anything. You know, I have people coming to me and telling me the most intimate details, and I really don't know them, but they see my face often enough in the community, so they trust me to tell me things. They trust me if I say, you know, try this doctor or go to this clinic, they will treat you right. They believe me. And so it's that trust that propels the client forward. They believe what you say. So, okay, I'm going to do this. I'm going to reach out to these people, you know, because you said that they're okay and that they're not going to judge me, and they're going to meet me where I am and not tell me what I need, but let me actually tell them what's going on and what I need. So that's another thing with the community health worker. We find out what the community is in need of, and we look for those resources. We try to find a way to bring the resources to the community from what they need. So my goal as a CHW is through education and prevention, from facilitating COVID shots and vaccination clinics here at my church. We do health fairs, and we have town halls on different health conditions like Alzheimer's or diabetes, or, you know, I'm starting a diabetes prevention program in March. And so my goal is to educate and run these prevention clinics so that people will understand that prevention is a lot easier to do than after you get the disease and trying to recover from the disease. So we try to tell them that through prevention, through healthy living, through these other things, that they can avoid the emergency room. And also educating the medical students on cultural engagement, you know, so when they get into the field and they get into clinic, they know how to treat people. They know how to react to people. They're not taken aback when you have 15 members of your family in the exam room with you, because they'll understand that, oh, this is the culture. So that's what I have to say about that.
The only thing I can add to what everybody else have said, we can about trust, because sometimes our communities have been taken advantage of by certain providers, and that's how there have been lack of trust between our community members and certain providers. It's because of things which have happened. I mean, sometimes we had researchers who come to our communities, they suck out information they need and we never see them back. Those are kind of things that bring mistrust. So as community health workers, we come back and try to rebuild the relationship because we want our communities to be involved in research studies or whatever other activities are happening in the community. And I think one of the reasons why community members, I mean, community health workers are successful in what they do is the method, like outreach methods that they use. For our community members to be involved, we don't just post flyers on buildings or sending emails. No, we do home visits. We go to our community members and inform them of what is happening. During community events, that's when we pass out the information. If there is a workshop going on, there is an event, there is a research study that we would like them to participate in. So these one-on-one home visits methods that we use, I think that's why we are able to become successful in involving and reaching out to our communities.
Yeah, I thank you all. I am lucky in my role to be able to work with all of these wonderful community health workers as well as some others. And the biggest thing that comes to mind every time I hear them talk about what they're doing and how they're involved, yeah, the first word that comes to mind is just advocate. And not just for the patient, for you all as well in your practices. They're advocates for both sides. They're a great bridge, and I think that's such a need, and I think community health workers are rock. Well, I think all of you that are on the call are rock stars. I just admire all of you for the work you're doing. But community health workers, I'm so appreciative of the work they're doing and in building those bridges, as you know, was touched on by each of these wonderful community health workers. We've talked about some of the obstacles that you face. I guess we'll kind of make this a double question. Are there any other obstacles that haven't been mentioned that are on the forefront of your mind that you'd like to address? And then the other thing is, and I talked about this in the first part of our series as well, you know, we all have work to do. We know that. We know there are improvements to be made, but I also love to focus on the successes that are happening and the good things that you're seeing. So if maybe you want to share a success story that's on the forefront of your mind, maybe your favorite, maybe a recent success story, I'll leave that up to you. But I like to see both sides of the coin, the obstacles and then the success. So I don't know where we want to start with that. I know that's kind of a messy way to phrase that question, but you're the professionals, the experts. So I'll leave that phrasing up to you.
I think to answer that question, I will use an example of COVID-19. I think it can be a good example to that played both roles in terms of what went wrong and what went well. When COVID-19 started, Before that, I could say that as community health workers, there were not many people who recognized our importance. It's like we were not known by anybody. Whatever we were doing in our communities, we were already educating communities, educating providers, but less people, paid attention to us. And then COVID-19 came, and the country was struggling to reach certain communities. Well, first of all, underrepresented communities got hit much because of health disparities that already existed. So there was a need, the country was in a need of how can we reach these communities? What would be the best methods to get to these communities? And I think the good thing that happened from there, I think the country realized that, community health workers are the best pathway for us to get to the communities. These are the people who know what is going on in people's homes. They talk to community members 24 hours. So that's when community health workers were recognized, and you can tell, the result shows how important and efficient what we did. We were able to communicate and passing resources, passing education to community members. So I think that's something that we should keep in mind, especially now that COVID-19 is slowing down. I would like to see what we were able to build should not be forgotten, because who knows what's going to happen again. Let's keep this strong and keep the capacity that we were able to build.
I'd like to add to what Valentine was saying about the COVID-19. In Utah, I think CHWs are being invested for years, doing a lot of volunteer working with state organizations, with the health department. And when COVID came, and for example, in our community, we were at that time 14% of the population in Utah, and more than 50% of our community was infected. And people, the health department was trying to reach that community, but they didn't know how. And when they involve us, all the community health workers, we could work in the community to go down all those numbers. But one of the things that happened as well is because we have those connections with people in those organizations, CHW, we were able to be part of the meetings with the government meetings where they were talking about how to help those our communities, and they listened to our frustrations, to all the feedback that we provide, because we were the ones that we were working in the communities, and there were so many systematic barriers to access to services for communities. And then on those meetings, we could provide that feedback that help us to change some access to resources. And I think that's one of the success that we have during pandemic. And, to be more visible to the community, what was the work that we did. And one of the things that Kathy said very well is the CHWs is a member of their own community. It's not someone that is going to just come and say, oh, I'm a CHW and I will work on this. No, the CHWs are part of the community that has the trust of the members of the community because it's part of that system, right? And that's one of the success during pandemic. I'm agree with Valentine was saying, and we work together in all this. One of my favorite things for me was successful, that all of us work together. Before each community was like working in their own communities. And during pandemic, we worked together with Kathy to have vaccines to all the communities. We work with Valentine, with Oretta, all together because we have the same goal to minimize those numbers. And that was one of the biggest success for me during pandemic.
One of the biggest obstacles that I have seen are, like I think it's Oretta said that people were not taking our profession seriously. They were thinking that we should just volunteer, that we're just there, by happenstance. And then finding resources quickly. And once we find the resources, we send someone to the resource that we have found, and then turn around and find out that they are being treated in a wrong way, in a way that's just not acceptable. And so that's a big obstacle. The successes I found were in the moment when we were able to navigate the system and get them somewhere, wherever they wanted to be, wherever they, that resource was, and they were able to achieve what they were looking for. That was, it's in the moment. And finding the right resources in a timely manner. Like Jeanette says, we all work together. So if there is something going on or someone needs something, we have our WhatsApp group, and we shoot it out there, and somebody, more than one, usually will have a solution or a resource or something. And so working together, I have found, because of the pandemic, is so rewarding, and we can surely cover a lot more ground together than we can separate.
I agree so much with all of what they have shared. Austin, we all appreciate you mentioning our advocacy on both sides, for community and for providers and for systems, because that is one of the things I think that sets us apart from a lot of the work that's being done across the nation. In fact, I serve on the National Association Community Health Worker Board, and they have looked to Utah for a lot of the things that we have done and been able to accomplish in the past 6 years, especially with COVID, to find out how we worked so well with state and government to accomplish all that we have accomplished in the past 6 years. And so we value this collaboration with providers, with systems, and with the government, with the state officials, because we know that we can't do the work on the ground without these resources. But until we literally fought for this recognition, until we were recognized, were we able to accomplish these things as well, because others began to see the value in the work that we do, especially on the ground. Because if you have worked with our communities, we know from the inside, it's a hard thing to do, to manage people and to work with different people at different levels of their motivation to do things it's a difficult job. And we've had to do this not only on community level, but on a systems level as well, trying to work with the different resources, what their policies are, what their processes are, and really explain to them why it's hard for community, but also explain to community the limitations that providers and systems have because of the way the policies are set up. And so we pride ourselves in this work that we've done in the past 6 years, especially through COVID, because we really have been a bridge for a lot of things going on in addressing equity. But one of the things I'll mention about barriers or struggles is the perspective that of territory, right? We've been looked at as now, why is this profession coming in now and taking my position? We do the same thing. I went to school for 4 years to get this degree. Why do they all of a sudden are they able to come in and either get the same pay as me or take positions? We really, that's not the intent of implementing this workforce. our intent again is really to become the extension of this work. This is why there's no standardization for what CHWs do, because our positions are tailored to the needs of the organizations. Where is the gap? Where is it the limit that you stop in providing services, and where can we pick up to make sure that our community members or your patients and your clients are getting connected to your services effectively? And the follow-up that we are not able to provide on a systems level because of overworked, staff, or caseloads are too much, or burnout, which is very real and is even more real after COVID. We have been there to pick up, where systems leave off or services leave off. And so we really want to, I don't know how you say, but take that myth away that we are not here to take over any other position or take their place. We're really here to, again, just be an extension of that work, because there's so much need. I mean, like you said, we're not going to solve all of this in one day or in one session, but the hope is, again, like everyone else has said, to do this together. And then I'll just end with the successes of all of this has been, we have passed legislation. We have organized community health workers across the state to provide these services. We are working in partnership with the systems and looking at more sustainable funding to support our workforce. And the biggest thing is we are building our own community health Utah Community Health Worker Association, where we can be more organized in partnering with the different sectors of work in Utah to make sure that our CHWs are protected and utilized in the way that they need to be with different sectors of this work. So a lot has been accomplished, and all of these women here have been an integral part of all of this success as they've been involved in advocating on the Hill in their different organizations, but most importantly on a community level, so that our community members know that something is being done, but we're not just here to connect you to resources. We're here to help you become a resource to your own families and to your own communities, and also successful contributors to the state.
All right. Well, I think we are at about 5 minutes left. I intended to leave more time and throw in those curveball questions, and that's what did us in. But I do want to open up this last 5 minutes. If you all have questions, you're welcome to unmute and ask those, or you can drop them in the chat and I can read those out loud. But yeah, with this last 5 minutes, if anyone has questions they want to ask, feel free to do so.
I have a quick question. My name is Amy Contreras. I'm the Chief Nursing Officer at a critical access hospital in the southern end of the state, Beaver County. So I admire all of your work that you guys have done, and so appreciative. Do you have anything that hits the rural communities? Do you have the big issue that we run into here? Like all of we get direct medical care here with the primary care section, but any kind of referral out to cardiology or nephrology, all of that is travel. And so we're fortunate that it's only an hour or hour and a half to the next city where some of those services are. But what we run into is that disparity of them not having a ride, or not having, even if they have a car, they don't have gas money, that kind of stuff. And we don't have resources. We don't have a taxi service around here. So it just really puts them in a bind. And one thing that was really positive with COVID was the whole telemedicine thing that really helped us a lot, but those are kind of going away as well. So any tips or advice that you can give us? And we don't have any folks like you either. It just usually ends up being nursing the nursing and the providers that end up doing all the work for that piece. I
don't know about the other women, but so we have graduated over 200 CHWs out of our core skills program, one which is out at SUU. So we do have CHWs out there. We also have our local health departments who have CHWs or health equity officers that we work in combination with. But I put.
You're mute, Oretta.
Sorry, I put my information in the chat. If we can connect, I can find out who those CHWs are, and if they're not exactly where you are, close, people who are close by there. One of the good things that CHWs can help with is finding that transportation within their support system. So whether it's through the churches or through their families, someone can help with that. So please email me or let me know, and I will connect you to someone there.
Hi, Amy. I will share with you my experiences. I've been working with the Delta community for the last year. And one of the things that I did, because they are kind of in the same situation, like the closest clinic for any treatment is like an hour and a half. And some of them, they have to travel from Delta to Provo Hospital to receive treatment. And we have exactly kind of the same. What I try to do in Delta is to create a task force with the health department, with the organization that are local. And we're trying to have a storm ideas about who can help us, or there is a business close that can help us, or who is the network that we have available. And we're trying to involve people in the community as well. You know, in Delta, I work with the Peruvian community that is growing so fast, and I involve them into this task force. And one of the things that we did with transportation is as an organization, work for a nonprofit organization, and we're trying to find grants that provide us, give us that option to work in the rural areas as well. And with these grants, what we do is we cover part of the travel, and then this group in Delta, they bring like halfway the people that need treatment, and we pick them up in the halfway to bring it to the closest hospital that they need. But that's what we did, right? Trying to find those grants that help us to work with the rural areas and create that task force in Delta, not just organization, but community members as well, because they are very involved in the community and they have the trust of the community as well. And together, we work together, and then we find a grant that help us to provide that half transportation. And that's the way we did it. And we are pursuing another grants this year that maybe can help us to do an assessment over their needs assessment, because we don't know exactly what are the needs in the rural areas in that area. That's what we did. That is my experience and what we've been done until now in that area.
Thank you both. I appreciate that.
I would like to just add to advocate to keep telemedicine, keep the telehealth going, because it is such a great resource for those that cannot get to. So please advocate to hang on to that. It's very essential for your patients.
Thank you, Kathy.
Yes, thank you all. And we are at our hour. I know a lot of you have to hop out. I know a lot of you join on your lunch hours, and want to thank all of you for being here, and especially want to thank our panelists for being here today. We'll just close. We had this chat come in from Gabriel from the Utah County Health Department. So for those of you that can't open the chat, he says, I helped interpret for a coworker with limited English proficiency at a doctor's visit. The doctor said to her, you've been here for 17 years and still don't know English. And he'd just laugh at her. And he says, glad CHWs are providing cultural competency to medical students to better engage with patients. And that's why what you all are doing is so critical, is to engage with people and to help train the existing practitioners as well as those who are coming up and gaining that experience to avoid situations like that, because that's just, it's unfortunate that those attitudes exist, and they have existed for a long time. And that's exactly what we're trying to combat. So those of you that are still here, you have Oretta dropped her contact information. You have my contact information. Don't hesitate to reach out. I can connect you with any of these panelists, as well as local CHWs in your area. So thank you all for joining, and we will see you in 2 weeks.